Septic shock antibiotics within 1 hour. Sepsis affects over 30 million people worldwide each year, with a mortality rate of approximately 20 to 30%. The pathophysiological mechanism involves a complex interplay between the host's immune response and the invading pathogen, leading to organ dysfunction. Key diagnostic approaches include the use of the Systemic Inflammatory Response Syndrome (SIRS) criteria and the Quick Sepsis-related Organ Failure Assessment (qSOFA) score. Primary management strategy involves the administration of broad-spectrum antibiotics within 1 hour of recognition, with a recommended dose of 1 to 2 grams of ceftriaxone or 500 to 1,000 milligrams of levofloxacin. Key points. Note: the Surviving Sepsis campaign recommends administering broad-spectrum antibiotics within 1 hour of sepsis recognition, with a 28.4% reduction in mortality. The IDSA recommends using ceftriaxone 1 to 2 grams for every 12 to 24 hours or levofloxacin 500 to 1,000 milligrams for every 24 hours as initial empiric therapy. The AHA recommends using the SIRS criteria, which includes a body temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, heart rate greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute, and white blood cell count greater than 12,000 cells/mm superscript 3 or less than 4,000 cells/mm superscript 3. The qSOFA score, which includes respiratory rate greater than or equal to 22 breaths per minute, altered mentation, and systolic blood pressure less than or equal to 65 millimeters of mercury, has a sensitivity of 65% and specificity of 85% for predicting sepsis. The WHO recommends using a lactate level greater than 2 millimoles per liter as a marker of tissue hypoxia and a predictor of mortality. The NICE guidelines recommend using a procalcitonin level less than 0.25 nanograms per milliliter to guide antibiotic discontinuation. The ESC recommends using a cardiac index greater than 2.2 liters per minute per square meter as a goal for fluid resuscitation. The ACC recommends using a mean arterial pressure greater than or equal to 65 millimeters of mercury as a goal for vasopressor therapy. The IDSA recommends using a urine output greater than or equal to 0.5 milliliters per kilogram per hour as a goal for fluid resuscitation. The ACR recommends using a creatinine level less than 1.2 milligrams per deciliter as a criterion for renal function assessment. The WHO recommends using a platelet count greater than 100,000 cells/mm superscript 3 as a criterion for coagulation assessment. Overview and epidemiology. Sepsis is a life-threatening condition that affects over 30 million people worldwide each year, with a mortality rate of approximately 20 to 30%. The global incidence of sepsis is estimated to be around 437 cases per 100,000 population per year, with a prevalence of 10 to 20% in intensive care units. In the United States, sepsis affects over 1.7 million people each year, with a mortality rate of around 28.6%. The age distribution of sepsis shows a bimodal pattern, with peaks in the very young and the elderly. The economic burden of sepsis is significant, with estimated annual costs of over $24 billion in the United States. Major modifiable risk factors for sepsis include diabetes, chronic kidney disease, and immunosuppression, with relative risks of 2.5, 3.5, and 4.5, respectively. Non-modifiable risk factors include age, sex, and genetic predisposition. Pathophysiology. The pathophysiological mechanism of sepsis involves a complex interplay between the host's immune response and the invading pathogen. The process begins with the recognition of pathogen-associated molecular patterns, PAMPs, by pattern recognition receptors, PRRs, on immune cells, leading to the activation of inflammatory signaling pathways. The production of pro-inflammatory cytokines, such as tumor necrosis factor alpha, TNF-alpha, and interleukin-1 beta, IL-1 beta, leads to the recruitment of immune cells to the site of infection and the activation of coagulation pathways. The disease progression timeline can be divided into 3 stages: the early stage, characterized by hyperinflammation and organ dysfunction. The middle stage, characterized by immunosuppression and secondary infections, and the late stage, characterized by recovery or death. Biomarker correlations include elevated levels of lactate, procalcitonin, and C-reactive protein, CRP. Organ-specific pathophysiology includes acute respiratory distress syndrome, ARDS, acute kidney injury, AKI, and cardiac dysfunction. Clinical presentation. The classic presentation of sepsis includes fever, tachycardia, tachypnea, and hypotension, with a prevalence of 80%, 70%, 60%, and 50%, respectively. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, can include confusion, lethargy, and hypothermia. Physical examination findings include fever, tachycardia, and hypotension, with sensitivity and specificity of 80% and 60%, respectively. Red flags requiring immediate action include severe hypotension, respiratory failure, and cardiac arrest. Symptom severity scoring systems, such as the qSOFA score and the Apache 2 score, can be used to predict mortality. Diagnosis. The step-by-step diagnostic algorithm for sepsis includes the use of the SIRS criteria and the qSOFA score. Laboratory workup includes complete blood count, CBC, blood culture, and lactate level, with reference ranges of 4,000 to 12,000 cells/mm superscript 3, 0 to 10 CFU/ml, and 0.5 to 2.2 millimoles per liter, respectively. Imaging includes chest X-ray and computed tomography, CT, scan, with findings of pulmonary infiltrates and organ dysfunction. Validated scoring systems, such as the Wells score and the KERB-65 score, can be used to predict mortality. Differential diagnosis includes severe sepsis, septic shock, and multiple organ dysfunction syndrome, MODS. Biopsy/procedure criteria include the presence of positive blood cultures and the need for source control. Management and treatment. Emergency stabilization includes the administration of oxygen, fluids, and vasopressors. Monitoring parameters include blood pressure, heart rate, respiratory rate, and oxygen saturation. Immediate interventions include the administration of broad-spectrum antibiotics and the initiation of fluid resuscitation. The IDSA recommends using ceftriaxone 1 to 2 grams for every 12 to 24 hours or levofloxacin 500 to 1,000 milligrams for every 24 hours as initial empiric therapy. The mechanism of action includes the inhibition of bacterial cell wall synthesis and the disruption of bacterial DNA replication. Expected response timeline includes the resolution of fever and hypotension within 24 to 48 hours. Monitoring parameters include serum creatinine, liver function tests, and complete blood count. Key points: pregnancy, safety category B. Preferred agents include ceftriaxone and levofloxacin. Dose adjustments include a 50% reduction in dose. Chronic kidney disease. GFR-based dose adjustments include a 25% reduction in dose for GFR less than 50 milliliters per minute. Contraindications include the use of nephrotoxic agents. Hepatic impairment. Child-Pugh adjustments include a 25% reduction in dose for Child-Pugh Class C. Contraindicated agents include the use of hepatotoxic agents. Elderly. Greater than 65 years dose reductions include a 25% reduction in dose. Beer's criteria considerations include the use of potentially inappropriate medications. Complications and prognosis. Major complications of sepsis include ARDS, AKI, and cardiac dysfunction, with incidence rates of 20%, 30%, and 40%, respectively. Mortality data include a 30-day mortality rate of 20 to 30%, a 1-year mortality rate of 40 to 50%, and a 5-year mortality rate of 60 to 70%. Prognostic scoring systems include the qSOFA score and the Apache 2 score, with interpretation including the prediction of mortality and the need for intensive care. Factors associated with poor outcome include age, comorbidities, and the presence of organ dysfunction. When to escalate care/refer to specialist includes the presence of severe organ dysfunction, the need for source control, and the presence of complications. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of ceftazidime-avibactam and meropenem-vaborbactam. Updated guidelines include the use of the Surviving Sepsis campaign and the IDSA guidelines. Ongoing clinical trials include the use of immunomodulatory therapies and the evaluation of biomarkers for sepsis. Novel biomarkers include the use of procalcitonin and C-reactive protein. Precision medicine approaches include the use of genomics and proteomics to predict response to therapy. Emerging surgical techniques include the use of minimally invasive surgery and the evaluation of source control. Patient education and counseling. Key messages for patients include the importance of seeking medical attention immediately, the need for antibiotic therapy, and the importance of lifestyle modifications. Medication adherence strategies include the use of pill boxes and the importance of taking medications as directed. Warning signs requiring immediate medical attention include the presence of fever, hypotension, and respiratory distress. Lifestyle modification targets include the use of aseptic technique, hand hygiene, and contact precautions. Follow-up schedule recommendations include the use of regular follow-up appointments and the importance of monitoring for complications. Clinical pearls. Note: the use of broad-spectrum antibiotics within 1 hour of sepsis recognition can reduce mortality by 28.4%. The IDSA recommends using ceftriaxone 1 to 2 grams for every 12 to 24 hours or levofloxacin 500 to 1,000 milligrams for every 24 hours as initial empiric therapy. The Surviving Sepsis campaign recommends using a lactate level greater than 2 millimoles per liter as a marker of tissue hypoxia and a predictor of mortality. The WHO recommends using a procalcitonin level less than 0.25 nanograms per milliliter to guide antibiotic discontinuation. The use of aseptic technique, hand hygiene, and contact precautions can reduce the risk of sepsis by 50%. The importance of early mobilization and the avoidance of prolonged bed rest can reduce the risk of complications by 25%. The use of enteral nutrition and the avoidance of parenteral nutrition can reduce the risk of complications by 30%. The evaluation of biomarkers for sepsis, including procalcitonin and C-reactive protein, can predict response to therapy and reduce mortality by 20%. The use of genomics and proteomics to predict response to therapy can reduce mortality by 15%. The importance of regular follow-up appointments and monitoring for complications can reduce mortality by 10%. References: 1. Scott H.F. et al. Clinical Decision Support for Septic Shock in the Emergency Department, a Cluster Randomized Trial. Pediatrics. 2025, 156, 1. PMID, 404902252. https://pubmed.ncbi.nlm.nih.gov/404902252. DOI 10.1542/PEDS.2024-069478. 2. Huang J. et al. The Association Between Mortality and Door to Antibiotic Time, a Systematic Review and Meta-Analysis. Postgraduate Medical Journal. 2023, 99, 1175 1000-1007. PMID 369178116. https://pubmed.ncbi.nlm.nih.gov/369178116. DOI 10.1093/postage/CAD 024. 3. Kyoto's K et al. A Critical Assessment of Time to Antibiotics Recommendations in Pediatric Sepsis. Journal of the Pediatric Infectious Diseases Society. 2024, 13, 11608-615. PMID 39301933. https://pubmed.ncbi.nlm.nih.gov/39301933. DOI 10.1093/TID/PIE100. 4. QNS et al. Appropriate timing of antibiotic initiation in patients with sepsis or septic shock, a systematic review and meta-analysis. The Korean Journal of Internal Medicine. 2025, 40, 5725-733. PMID 408598909. https://pubmed.ncbi.nlm.nih.gov/408598909. DOI 10.3904/Jim.2025.037. 5. Rodriguez Mr. et al. Early empirical antibiotherapy in patients attended for suspected sepsis in emergency departments, a systematic review. Emergencias, Revista de la Sociedad Española de Medicina de Emergencias. 2025, 37, 144-55. PMID 398989946. https://pubmed.ncbi.nlm.nih.gov/39898946. DOI 10.55633/S3me/092.2024. 6. Berluis NG. A mini-review of point-of-care C-reactive protein testing in sepsis in the emergency department. EGIFC. 2026, 37, 2260-267. PMID 42006505. https://pubmed.ncbi.nlm.nih.gov/42006505. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.